The next speaker, again, not to be outdone, is a young man who's on a great trajectory, and I really look forward to hearing from him. He's single-handedly really started this unit at Temple University, and now is not single-handed. He has a teammate on the flow side, which is terrific, and he's an extremely clear thinker that has done some really important work so early on in his career. Again, from Temple University is Andy Meyer, who's going to speak to us about A Tale of the Knights Templar, terrific treatment teams at Temple University. Ladies and gentlemen, please help me welcome Dr. Andy Meyer.
Well, thank you very much, ladies and gentlemen. We've literally heard from just about every corner of the earth this morning, and I guess it's my job to try and make the wilds of North Philadelphia seem just as exciting and just as exotic as some of these places. It is a challenging and interesting socioeconomic environment, and when we set out to implement a limb salvage team at Temple University, we did kind of think about some broad and rather philosophical concepts as we put our team together. And I'm happy to share those with you today and hopefully have a discussion about them over the next couple days. The first thing that we did was we tried to work on efficiency. Now I'm having problems too. There we go. Perhaps the first thing I could tell you about efficiency, and to try and make this clear, is introducing you to the history of Temple University. This is our founder, a Baptist minister named Reverend Russell Conwell, who had a Baptist church up in North Philadelphia, and one day one of his adult practitioners or parishioners asked him for some tutoring, and so he did. And Temple University started from these humble origins. He tutored one student in the church basement several times a week. And then there was a couple more students, and a couple more students. And next thing you know, 100 years later, we have over 35,000 students at Temple, over 18 colleges on 9 international campuses. And specifically for me, we have a 721-bed health science campus at a level 1 trauma center. Now, with so many resources that we now have available, things should run very easily for us, right? Well, of course, that's not the fact. As structures and organizations get larger, they also have a tendency to become less efficient. This is a picture that I took from the men's locker room at our operating rooms, and we were out of soap in the bathroom. You can see that we had been out of soap for so long that we had literally opened up the canisters of the soap to show that there's no soap. And someone was nice enough to put out a bottle of hydrogen peroxide in case you were really desperate. I thought this was hilarious, of course. Now, was Temple University Hospital out of soap? Of course it wasn't. We probably had a whole room in the hospital dedicated to soap. There are boxes and boxes of soap there. The problem was a breakdown in the efficiency, bringing the resources, the soap, to the people that needed them, me, who had just gone to the bathroom. Again, as structures get bigger, they also have a tendency to be less effective. And I do think that we have at least the potential for this within the field of diabetic limb salvage. There's absolutely no doubt that a multidisciplinary approach to diabetic limb salvage is a good thing. Everyone in this room is a testament to that. This meeting is a testament to that. We heal more wounds, we do less amputations, and we have increased levels of patient satisfaction. But when you start adding up all the potential members of a multidisciplinary limb salvage team, it gets crowded, and it gets crowded very fast. This is a lot of cooks in the kitchen, and I guess I would kind of make the argument that if all of these different multidisciplinary members are treating the wound, then there's actually no one treating the wound. It's not a very efficient process. This is not just something that I think we all understand conceptually. I think we can see this through our literature. My team recently undertook admittedly a little bit nerdy study recently where we looked at where diabetic foot literature is published. And what we did was we did a relatively broad search of diabetic foot disease topics, and we searched it every year from 1988 to 2012. So we searched these terms in 1988, 1989, 1990, and so on, and we found, somewhat unsurprisingly, that the amount of published literature on the diabetic foot is increased. And it's increasing at greater than just a linear rate. This is a good thing, right? We have more literature, we can make better decisions, we can treat our patients more effectively. Well, if it loses efficiency and it gets too spread out, then we can't necessarily use that information. We took all of the articles that hit those PubMed search criteria in 2012 And we went through each of those abstracts and essentially decided if someone at this meeting should read the article. In other words, does this article contain information that's relevant for someone working with diabetic foot disease? And we came up with over 1,200 articles that were published in over 659 journals that were relevant to people in this room. If you kind of do the math on that, that means that everyone here has to read 3.5 articles a day, and you have to go through 13 different journals a week in order to stay current on our literature. It's very, very spread out. And when I see that being spread out, I kind of go back to this picture. There are a lot of different members of the team, but if you're not working together and you're not working synergistically, then the efficiency of the system goes down. So what we sought out to do was to, yes, have a big multidisciplinary team, but we organized it a little bit and essentially kind of assigned everyone to different levels. And the kind of groups that we think of is that I've kind of have more peripheral members of our team. It's not that they're less important, it's just that I don't need to speak to these people every day. The way that I kind of think about the peripheral members of my team is that I personally will speak to them at least once a month. How's everything going? Any patients you want to talk about? What can we be doing better? If I need them, they'll return my phone call within 24 hours. And if my patient needs them, I can get them in to see within about a week. Another thing that we do to help kind of keep these more peripheral members involved is that we have multidisciplinary journal clubs, and we really did this based on our literature review. So once a month, the radiologist, for example, will come talk about interesting diabetic foot literature that's been published in the radiology journals. I love our PM&R guys, but I don't need to talk to them every day. But about once a month, we'll have them come in and tell us what interesting things have been done and published in the PM&R literature. Then kind of the inner circle is more kind of the day-to-day members of our team. These are people that I speak to, not necessarily on a daily basis, but certainly on a weekly basis. These are people that I need to return my phone call in a couple hours if I need them. And if my patients need them, I want them to be seen either that day or the next day. We have that type of relationship. And these are members that participate in our weekly team meeting. Every Tuesday morning at 7:30, we review angiograms, look at x-rays, talk about patients that we have in-house. And that inner circle is people that I talk to not just every day, but several times a day. It's my nurse practitioner, our residents, and the patient, of course. These are people that, again, I speak to multiple times a day, without exception. And then kind of in the middle of this, and something that may be a little bit different, obviously we do follow a toe-end flow model, but I think that with every patient there needs to be one captain of the team. So really with this we think about toe or flow. And there has to be one person who's making the decisions for that patient. There's lots of input from other people, but there needs to be a kind of a team captain. And that could either be our foot team or it could be our vascular team. And this is something that we explicitly communicate. I have a great relationship with our vascular team, and we kind of say, this is a foot problem that also needs some vascular work, or this is a vascular problem that really also needs some footwork. There's no fighting between the team. The residents don't fight with themselves about, well, this patient should be on your service or our service. This is something we explicitly define every time it comes in. And when you really kind of break it down, we do absolutely follow a toe and flow model. And we think that you really only need 3 members of your team. I need a passionate toe guy, and I need a passionate flow guy. And it's not just enough to be able to do these surgeries. You have to be able to kind of want to do them. I see Dr. Gibbons in the audience who's very fond of saying that you should never let the sun set on a diabetic foot infection, and I couldn't agree more. But that can be challenging sometimes, and to be perfectly blunt, it could take a lot of passion and energy in order to do that. I was on call last week, and I had a patient with a 4-foot abscess that needed to go for an open TMA, and I got bumped by 2 gunshot wounds and a stab wound and someone that had AAA. And I didn't actually physically get into the operating room until 10 o'clock at night. Now, you need passion in order to do that. Same thing with the vascular guys. Anybody can kind of do these procedures with a certain amount of training, but I need someone, if they have severe infrapopliteal disease and I'm not getting anything, someone that's willing to spend 2 hours trying to get across a block of calcium in the anterior tibial artery to get some type of inflow to the foot. The second big concept that we kind of address is that we really don't necessarily have too much time for complications and recurrence. This may be somewhat of an unpopular opinion, but there are certainly times that I think to myself that diabetic foot disease is a war that we may not win. We're doing a great job right now. We win some battles, we lose some battles, but if you think about it from the big picture, it's very, very challenging, and it's not necessarily going to get much better. I am not an epidemiologist, so please pardon my kind of rather crude math on the subject, but in the United States, there are about 30 million diabetics, and there are about 15,000 podiatrists. Now, assuming that all 15,000 of those podiatrists are passionate about diabetic limb salvage, which of course they're not, that means that essentially every foot doctor has a quota. That's the way that I kind of think about it. And so I have a quota of 2,000 diabetics. And then if I know that about 20% of diabetics are going to go on to develop an ulceration, that means that my quota, am personally responsible for about 400 foot ulcers. I felt bad about myself as I was putting together these slides, but then you look at those numbers from China, and oh my gosh, I don't know what their quota is. That's unbelievable. So when I have that patient with a foot ulcer, I'm not an economist either, but I kind of view that as somewhat of a sunk cost. When that wound develops, whether it goes on to heal or whether it goes on to an amputation or whether it goes on to something else, that's going to cost a certain amount of money. And when I have that one person from my quota, from my 400 that develops that ulceration, I want to get them off of my list essentially as quickly as possible. I don't want this patient to develop a recurrence, to have an ulcer, me cure it, and then have it come back and come back and come back. That keeps my list or my quota constantly increasing. I want to be able to decrease my quota as opposed to increasing. So what we do at our limb salvage center is we really take a view, and we're very aggressive with respect to interventions that we think at least are predictable and are going to have long-term sustainability. And again, it's very challenging and it's very almost eye-opening when you look at all this economic data. And I really don't think that as the number of diabetics increase and as it gets more and more expensive, when you think about it, we literally don't have the time or the resources for a failure of my intervention or a recurrence of an intervention. This is an article, and there have been several kind of on this topic. This was one of my favorite ones, an article by Tom Ruckus who looked at re-amputation rates following any first ray amputation. So if you lost any portion of your first ray, he did a systematic review and found that about 20% of those patients will develop a re-amputation within 2 years. That's too many, and that's a lot of recurrences. Even more interestingly, he thought it was a high number too, so he went back and looked at his own center and looked at all the first ray amputations that he did and found that his number of reamputation was even higher. It was close to 50%. These are numbers that are not sustainable long term. And kind of on this topic, and when I'm thinking about this, we've really kind of changed the way that we view our diabetic foot pathology. Whether we're talking about a blown out foot infection or tissue loss with critical limb ischemia or some type of awful rear foot Charcot, or even something as simple as a patient who has a hammer toe following a hallux amputation, what we're doing with diabetic foot disease and our surgical interventions is just different. I think for most of us, when we were trained, you think about a patient has some type of disease process, and our goal of our interventions is to, quote, cure them. We want to get them back to normal. We want to get them back to their baseline. But the fact of the matter is that diabetic foot pathology changes what the definition of normal is. They are starting with an anatomic failure. So I need to think about my interventions in terms of not giving them a normal foot in terms of its anatomy and function. I want to give them a different foot in terms of its anatomy and function. I want to try and predict my recurrences. I want to try and predict my problems as much as I possibly can to try and avoid this. I'm not returning to normal. And in another way, so when I see a patient that presents with diabetic foot pathology, I don't necessarily think about trying to reconstruct their foot. I think about trying to deconstruct their foot. This is just a difference in semantics, granted, but like if you think there's Veterans Stadium down there in the bottom corner, if you have a building that's going to need to come down, you could either explode that building and have a big mess, or you can implode the building and try and minimize your damage and control the situation. And that's kind of what we think about. We deconstruct the diabetic foot. We implode the diabetic foot so that we don't have an explosion. And when we do this, I call it reasonably intelligent limb salvage, because we all do dumb stuff sometimes. And we don't exactly know what to do in all situations, but there are probably relatively intelligent ways to do things and relatively unintelligent ways to do things. This picture in the top left, is there any way that he doesn't go on to develop a hallux ulceration over the coming years? Or the X-ray, is there any way that that patient doesn't go on to develop a hallux ulceration or a submet 4 ulceration? Or my patient with a hammer toe and a hallux amputation, that could have been predicted, that hammer toe would progress, develop a distal ulceration that would probe to bone and require more interventions. These are not sustainable procedures. And again, I don't think we always know what to do in every situation, but I think all of us have an idea about what not to do in most situations, and we need to kind of listen to that voice a little bit more. So, generally speaking, when I'm dealing with a hallux amputation or a first ray, I kind of think about it in 2 levels. If at all possible, I leave the base of the proximal phalanx, if my tissue and my perfusion lets me do that, so that I maintain some type of length. But if I can't do that, I usually jump back more proximal. And I do that so that I can use the abductor hallucis for coverage of my area. I also know this is at a high risk of developing a problem in the future. Once you lose the first ray, my normal anatomy of foot and ankle function forever changes. So we are very aggressive with respect to predicting what's going to occur. We can't always do prophylactic procedures at the same time, but we will always try and plan to do prophylactic procedures as soon as we're sure the infection has cleared and they're going to heal their primary procedure. So we do a detailed examination for hammer toes and do flexor tenotomies or PIPJ arthroplasties or even pan-metatarsal head resections if needed down the line. And we're a little bit more aggressive now with doing tendo-Achilles lengthenings just following first ray procedures. Same thing with a TMA. A TMA is generally thought of to be a relatively reliable procedure, but it's not if you don't do an appropriate vascular examination ahead of time. We will usually do a prophylactic TAL at that same time, and we've been paying a lot more attention to frontal plane alignment. These have a tendency to go into a little bit of varus, so sometimes we think about doing TA tendon lengthenings, like Paul Kim talks about at Georgetown, or anastomosing the perineal tendons on the lateral side to try and prevent some of these. With midfoot and rear foot amputations, we have to kind of come to grips with what this is, and it really is kind of a salvage procedure to some degree. If something goes wrong, if I get a recurrence of an ulceration with a midfoot or rear foot amputation, there's not too much that I can do. Those are very difficult. So we educate our patients that to some degree this is a salvage procedure, and if something goes wrong with this, if it doesn't work, we're facing major amputation. Charcot deconstructions are the same thing, and this is really the epitome of what I think about in terms of an anatomic failure. This patient's normal anatomy has failed them, so when I try to give them something else, when I try and, quote, fix the situation, I'm not trying to build them a normal foot and ankle. I'm trying to build them something different that's going to last for a lot longer and be more supportive. I almost forget the concepts I learned in terms of reconstructional foot and ankle surgery where we're trying to preserve function. This is different. And then really, I try and close as much as possible with respect to this. Here's a patient on the right that had a first ray procedure that I wasn't able to close my soft tissue, so I did a synthetic graft and I'm using a wound vac. I'm sure this patient is going to heal, but it's going to take a lot longer for them to go on to heal. They're going to have home nursing, probably a longer course of antibiotics. They're not going to be self-sufficient. They're not going to be working. Where if I just primary closed it. Usually at these meetings we have arguments about what's the most important outcome measure with respect to diabetic limb salvage, and where there can be different ones for different situations, but when I see diabetic foot pathology, I think to myself, how can I most quickly return this patient to wound-free ambulation? The third big picture concept that we do, if you're familiar at all with Philadelphia and Philadelphia area sports, you know we don't have the best reputation. Yes, one time at a Philadelphia Eagles game, we threw snowballs at Santa Claus. Yes, there is a jail located in the Philadelphia Eagles stadium. This is kind of a provincial thing. We're not afraid to be blunt, and we're not afraid to say no. This is a patient who you all know, although not specifically, who presented to our clinic with a hallux amputation. Nearly 12 months later, after they failed the first ray amputation, the TMA, the rear foot amputation, They went on to a major amputation. The BK didn't heal, and he eventually ended up with an above-knee amputation, which eventually healed with adjuvant negative pressure wound therapy. Now, what happened when he came back to me with a hallux ulceration on the opposite side? I told him we are not going to go through all of those things again. It's absolutely okay to kind of say no. We told him we would maximize his blood flow as we could. We would try one partial type foot amputation. Otherwise, we're looking at a major amputation. I say no to diabetic patients all the time. This is some of Dr. Vukic's data looking at the diabetic patients are different. 5 times as likely to develop a postoperative infection. A neuropathic diabetic patient is 10 times as likely to develop a postoperative patient. It takes a lot for me to perform elective surgery on diabetics with an A1C greater than 8. If their glucose is over 200 in pre-op, I cancel it. And if they have a BMI greater than 40, I'm also probably not going to recommend a reconstructive procedure to you. This, to some degree, is psychiatric. Our group recently looked at Kubler-Ross's 5 stages of grief and tried to relate them to diabetic foot disease. And obviously one of those stages is denial. And I think both ourselves and the patients, to some degree, have denial with respect to this situation. The pathogenesis of diabetic foot disease isn't good, but you have to kind of come to grips with what it is. You're not going to save every limb. You just absolutely won't. I said at the beginning that I really needed 3 members of my diabetic limb salvage team. We need toe and we need flow, but I also think you need kind of a cynic as part of your team too. You need someone who's going to be seeing these patients with you, and you're going to need someone to say no, because we do kind of get ourselves into denial sometimes. We have to appreciate and we have to come to the grips that we're not going to save every single leg. And if you take a step back and if you look at it, you can probably save your patient a lot of time and certainly save a lot of resources by trying something that ends up being relatively futile. The fourth thing that we do is we try and keep in mind big picture concepts of expectations and responsibility. And this kind of goes into a little bit about saying no. Dr. Boulton is also in the audience, and he famously came up with the triad of diabetic foot disease. If you have these 3 things, you're very likely to end up with diabetic foot disease. And unless you're intervening at each of those stages, it's very likely that it's going to continue. You have to appreciate from a big picture who you are as a physician. There are some things that we're able to change, and there are some things that we're not able to change. And this is just a difference in philosophy. We like to say at our Limb Salvage Center that we have never actually healed a wound. I haven't been practicing for decades, certainly, but nothing that I've ever done has healed a wound. All I've ever done is put my patient into a better position to heal themselves. And I think sometimes we take things a little too personally. How many times have you said that you've lost a leg of a patient that you've been dealing with for years and years and years? It's great. That means that you care. That means that you have passion. But you, in fact, didn't necessarily lose the leg. You have to understand that there are some things that you can control and some things that you can't necessarily control. I usually end my talks with a slide like this where we go over kind of big picture concepts of my talk. But if you'll allow me, I'll instead show you my favorite Philadelphia landmark. So we have a lot of historical landmarks in Philadelphia. Liberty Bell, Independence Hall, the first White House was there. But this is my favorite, and this really kind of brings big picture concepts together for me. This is relatively indistinct. Most people just kind of walk by it. But this is the Thomas Jefferson House. So diabetic limb salvage is a big picture concept with a lot of potential problems, and it takes a lot of input to get into it. Just like America was, right? America is a big picture concept, and it took a lot of people to bring that together. But Thomas Jefferson had to sit down and physically write the Declaration of Independence in order to get America started. And anyone who's ever done any type of research has had the feeling where you've done a project and you're sitting at your computer with a blank screen and you physically kind of have to write it. That's kind of like a spiritual thing for me. I really enjoy that. As big as the concept of something is, it takes one person doing one thing in order to bring it to fruition. And if I ever get a little too overwhelmed with big picture concepts in diabetic limb salvage, I think of that. And I say to myself, all I can do is help one patient at a time. So I take a deep breath, I think about the next patient that's on my schedule, and I don't think about all the big picture things. I just go into one room, I see one patient, and I do everything that I can for one patient. And then I do it for the next patient. And then I do it for the next patient. And the next thing you know, you go from the Declaration of Independence to America. You go from Dr. Conwell tutoring one student to big old Temple University. All right. I thank you very much for your time. Thank you.